not had a chance to do your exam 2 analysis yet. So until I'm able to go through that, I want to wait to go through that to see if anything needs to be awarded back. Then I can accurately do a review with you. So we're just going to do the study session this evening for your midterm. And then next week, I will do 2 exam reviews after our study session. So whenever you talk about the nervous system, there are 2 divisions of your nervous system. You have your central nervous system and you have your peripheral nervous system. So 2 divisions of your central nervous system, the central nervous system and your peripheral nervous system. Your central nervous system is going to be things like your brain, your spinal cord. The central nervous system is responsible for things such as thinking, memory, coordination. So CNS, brain, spinal cord, thinking, memory, coordination. Your peripheral nervous system is everything outside of the brain and spinal cord. It's going to be things such as your somatic nervous system and your autonomic nervous system. Your autonomic nervous system is going to control things such as your breathing, your heart rate, digestion. So you have your central nervous system that has your brain and your spinal cord, responsible for thinking, memory, and coordination. You have your peripheral nervous system. That's kind of everything else outside of your brain and your spinal cord. Located in the peripheral nervous system, you have your somatic nervous system and your autonomic nervous system. Your autonomic nervous system is going to be responsible for things such as breathing, heart rate, digestion. Autonomic, think of it as automatic. Autonomic, think of it as automatic. It's not consciously controlled. The next thing I want to talk to you about is your sympathetic nervous system. So your sympathetic nervous system, the biggest thing that you need to remember is that it's activated by fight or flight. So your sympathetic nervous system is activated by fight or flight. When your sympathetic nervous system is activated, you're going to have things happen that kind of speed things up. So you're going to have a faster heart rate. You're going to have dilated pupils, bronchodilation. You're going to have increased blood pressure and a dry mouth. Think of a time when you get scared. That's when your sympathetic nervous system is going to be activated. So sympathetic, fight or flight. You have a faster heart rate, dilated pupils, bronchodilation, increased blood pressure, and a dry mouth. The opposite of that is your parasympathetic. And the symptoms of that are equally opposite of your sympathetic. So parasympathetic, you're going to have rest and digest. You're going to have a slower heart rate, constricted pupils, bronchoconstriction. You're going to have a decreased blood pressure and increased saliva. So parasympathetic, rest and digest, slower heart rate, constricted pupils, bronchoconstriction, decrease blood pressure, and increase saliva. Whenever you have your sympathetic, kind of want you to remember that everything speeds up. So your sympathetic, everything speeds up. When it comes to mimicking the sympathetic nervous system, we give medications that kind of mimic that um, reaction. We give epinephrine and we give norepinephrine. So you're going to give these medications in things such as cardiac arrest, shock, anaphylaxis. So I'm going to say that again. We give medications that mimic the sympathetic nervous system. We're going to use epinephrine and norepinephrine. Those are the medications that we're going to give. And we use these in things such as cardiac arrest, shock, asthma, and anaphylaxis. When we're talking about anaphylaxis, if I just told you that about those medications, what medication do we give for anaphylaxis?
Isn't it epinephrine?
Yes. Why do we give epinephrine? What is the therapeutic effect or the goal of epinephrine? What does it do to the body? Why do we choose epinephrine in patients with anaphylaxis?
Doesn't it? I mean, if they're having an allergic reaction, doesn't it like trigger the opposite to bring everything back down?
Yes, but to feed off of that, the actual reason you're right, but I'm going to just feed into it a little bit more. So we give the epinephrine because it causes bronchodilation. So we give the epinephrine because it causes bronchodilation and it raises the blood pressure. Let's talk a little bit about some side effects of the
Will you go in there
epinephrine.
and answer that and tell him I'm on?
Let's go into the side effects of the epinephrine and norepinephrine that are activated because of the cardiac arrest, the shock, and the asthma. So, some side effects of these medications are going to be things such as hypertension, tachycardia, palpitations, and anxiety. The next thing I want to talk to you are about are adrenergic blockers. So, adrenergic blockers are medications that relax your blood vessels. We mostly use them to lower your blood pressure. So we have what's called alpha blockers. There's adrenergic blockers, and your two types are alpha blockers and beta blockers. The alpha blockers, we use those to relax the blood vessels. So your alpha blockers relax your blood vessels. Then we have our beta blockers. Your beta blockers are going to decrease things such as your heart rate. They're going to decrease your blood pressure and they're going to increase contractility. So when you think about your beta blockers, you want to always think that it lowers. Beta blockers lower the heart rate, they lower the blood pressure, and they lower your cardiac workload. Tell me a therapeutic effect of a beta blocker. What what is expected of a beta blocker? You have a patient that's prescribed a beta blocker, what should we expect?
A lower than normal heart rate or blood pressure.
Not lower than normal, just decreased. Lower than normal makes me think that it's like actually lower than you want it to be. So just a decreased blood pressure would be a therapeutic effect or a normal effect of a beta blocker. Could also be a lower heart rate. That would also um, fall into that category. So if you have a beta blocker, you're going to expect that your patients are going to have a decreased heart rate and a decreased blood pressure. Let's talk a little bit about this parasympathetic. So they're the medications that are going to mimic the parasympathetic system. The major one that you want to talk about is acetylcholine. So acetylcholine is going to cause relaxation. An example of this an acetylcholine medication is pilocarpine. So these are your parasympathetic medications. Acetylcholine is the medication and it causes relaxation. An example of this medication is the pilocarpine. We use this medication for open angle glaucoma. We use this medication for open angle glaucoma, pilocarpine. Sometimes there's times when we can't use this medication though. We can't use this medication if the patient's severely bradycardic. We can't use this medication if it's causing the patient to have bronchoconstrictions. Another medication type is anticholinergics. An example is atropine. Atropine is used to dry everything up. So if your patient is getting atropine, you're going to find that they have things such as a dry mouth. You're going to find that they have dilated pupils. They have decreased secretions. And they can even have urinary retention. So atropine is commonly known to cause urinary retention. So a lot of times whenever you have a patient that is um, has symptomatic bradycardia, they're going to be given the atropine. So we use atropine to treat symptomatic bradycardia. Let's talk a little bit about the different types of pain medications. So you have acetaminophen. Acetaminophen can be given for pain and fever, but it doesn't affect inflammation. Acetaminophen does not have any effect on inflammation. So it's good for pain and fever, but not for inflammation. Your NSAIDs, they're good for all three. NSAIDs will effectively control or help pain, fever, and inflammation. So will your aspirins. What drug class is aspirin? What drug class is aspirin?
Isn't it anti-inflammatory?
It does have anti inflammatory properties, but what drug class is it? That is also another reason that we use it. But aspirin falls under your salicylates, SALICYCLATES. Salicylates. Aspirin is a salicylate. What about morphine? What drug class does morphine fall under?
Is it an opioid?
Yes, it is an opioid. Morphine is an opioid. And morphine's really good for pain, but it doesn't have any properties that would be good for fever or inflammation. It's only a pain medication. So if I ask you which of those medications has no anti-inflammatory properties, which ones would you tell me?
Acetaminophen
And
and morphine.
exactly. So your NSAIDs and your salicylates or your aspirins, they are going to um, be helpful with all three: pain, fever, inflammation. If I ask you what medication has no anti inflammatory properties, you are going to tell me acetaminophen or morphine or your opioids. So now let's talk a little bit about each of those, some important properties about each of those. So aspirin, never give it to children, um, especially with viral illnesses. It's known to cause Ray's syndrome in the children, and overuse of it can cause GI bleeding. Morphine, what's our priority assessment with morphine?
Airway,
Airway or
respiratory depression.
respiratory rate? Yes. So your priority assessment or worry with morphine is going to be the respiratory rate, because morphine or opioids, they are more likely to cause respiratory depression. So your priority assessment for that is going to be the respiratory rate.
Can you repeat what aspirin
Yeah.
causes?
Yeah. Yes. So aspirin, we never want to give it to children with viral illnesses. We also never want to give it to children, actually, period, because it causes Ray's syndrome, REYES syndrome. And you'll see that on the back of the aspirin bottles. So if you had a patient, respiratory rate is 12, are you going to give the opioid or not?
No.
No, you are not going to give the opioid. You're going to hold the opioid, you're going to assess the patient, and you're going to notify the provider. So we don't want to give opioids for a respiratory rate less than 12. Naloxone is our reversal for opioids. We use this in opioid overdose. But there's an important thing to remember with that. With your naloxone, you need to remember that your half life is shorter than the morphine. So the patient could become sedated again and they may need another dose of the naloxone until that half life of the morphine has been run through.
The
So,
half life is shorter
yes,
than that of morphine.
yes. So the medication doesn't last as long as the morphine does that's already in their body. So naloxone, the half life is shorter than your morphine, and the patient is at risk for becoming sedated again.
Now, is that just for morphine or is that any opioid?
Any opioid.
Okay.
Any opioid overdose, you would give the naloxone or the Narcan. They're interchangeable. Same medication, just different names for them. Okay, so let's talk a little bit about a patient that we have here. So we have a patient, the respiratory rate is 8. They're hard to arouse. Their blood pressure is 90/60. What's our priority?
Airway and possibly give Narcan.
Yes, so our priority is airway, and we're concerned for respiratory depression. And our action is going to be to give the Narcan or naloxone and support airway and breathing. Very good. I saw briefly on your quiz that there was a question about your quiz from last week, that there was which led me into this thing about I need to look at it and do a test analysis. But the reason I'm saying this is because I saw a question that was on your quiz last week about a sleeping medication. I think it was maybe about Ambien. Is that
Yes,
ring a
that
bell?
was on there.
So I know that I'll be giving points back for that one if you happen to miss that one, because I'm going to cover that right now. So whenever you talk about your anxiety and sleep medications, we have different categories. So we have benzodiazepines. Benzodiazepines are going to be things such as your lorazepam, your diazepam, and your alprazolam. What is the what's the similarity in these medications? The way that they are written, what's the similarity?
The INES.
It's the ending.
Yes, the endings. The
Yeah.
endings are all the same. So your benzodiazepines are usually going to end in your PAM. So I said those examples were lorazepam, diazepam, and alprazolam. What do we use benzodiazepines for? What are some uses?
We give them at work for patients that are going to have like CT scans and they're nervous, or MRIs and they're
Yeah,
nervous.
yeah, for sure. So they can be used for anxiety. We can use these for seizures. We can also use these medications for alcohol withdrawal. Some side effects of these medications, a big thing is that your patients are at risk for falls. Sedation is another side effect, respiratory depression, and dependence. So, side effects are falls, sedation, respiratory depression, and dependence. The next one is SSRIs. Your SSRIs are going to be things such as your sertraline, your fluoxetine, citalopram, sertraline, fluoxetine, citalopram. Those are all SSRIs. These are our first line medications for depression and anxiety. Your SSRIs are your first line medications for depression and anxiety. We talked a little bit about this last week. I want to touch on it again. Which antidepressant class requires dietary restrictions? And what is the dietary restriction?
MAOIs and it's tyrosine.
Tyramine? Yes, perfect. And what is the tyramine?
Cheese and meats.
Yeah, things that have been aged. So it's your aged cheese, your meats. Um, that is perfect. And we said that it was the MAOIs. So antidepressant class that requires dietary restriction is your MAOIs, and the dietary restriction is tyramine. We have a couple of seizure medications that we need to know. You have your hydantoins, HYDANTOINS, and you have your phenytoins. Seizure medications are commonly going to end in the TOIN. That's their common ending. An important thing with your seizure medications is that we have to monitor drug levels because we have to make sure that that medication is staying therapeutic in the patient's body. Because if the medication is not therapeutic, then they're going to need either a dose increase or a dose decrease. We want to maintain that therapeutic level. That's what keeps the patients from having seizures.
Phenytoin and what was the other one?
Hydantoin, HYDANTOIN. When it comes to your tonic clonic seizures, those are the worst seizures that you can have. Their whole body. We use a different medication for that. We use phenobarbital, PHENOBARBITAL. Phenobarbital is commonly used for your tonic-clonic seizures and for your febrile seizures. What other medication did I tell you that we commonly use in seizures?
Versed.
So yeah, you could use the Versed in the hospital setting. Yes, you could use the Versed. The one I'm looking for is benzodiazepines. So we use those benzodiazepines in the hospital for emergency seizure medication. Those are going to be your diazepam or your lorazepam. So benzodiazepines are used for emergency seizure medications. Those are going to be your diazepam and your lorazepam. What is an absent seizure?
It's where they don't convulse. They just have like sometimes they zone out. They have their eyes blink a lot. They continue in like a movement that they were just in. They'll like if you ask them a question, they'll like zone out. They won't answer you, but they'll start back up
Yeah,
from where
absolutely.
you left off. My son has them. I'm sorry.
You're okay. No, perfect. Thank you. That's great. Oh, I got to pause for just a second. I got to plug my computer in. The medication that we give for your absent seizures, there is a specific medication that we like to use for absent seizures. It's called ethosuximide. ETHOSUXIMIDE. Hold on just a second. I'm going to grab my charger. Ethosuximide. ETHOSUXIMIDE. And that's used for absent seizures. So what do we use phenobarbital for?
Tonic
Tonic.
seizures.
Yep, tonic-clonic seizures and your febrile seizures. Give me an example of a seizure medication that's not phenobarbital.
Diazepam.
Diazepam is a benzodiazepine.
Kepra.
Keppra is one. Yes, we use that one for seizures as well.
Lamidogene.
Yep. Lamictal is the other name for that. All of those are seizure medications. Okay. And then what do we use for the absent seizures?
Ethosuximide.
Yes, exactly. All right, let's move on to mood stabilizers and antipsychotics. So, your mood stabilizers and your antipsychotics, commonly we use a medication called lithium. Lithium is a common medication that we use, but it gets a little tricky because it has a narrow therapeutic range. So, patients that are on lithium have to be monitored very carefully for toxicity, lithium toxicity specifically. So we have to check their blood levels. Patients that are on lithium, you'll find that they have to get blood drawn pretty frequently in order to monitor their blood levels. You want to teach these patients that are on the lithium, you want to teach them to maintain a sodium intake. You want to teach them to stay hydrated. You want to teach them to don't suddenly reduce their dietary salt. That medication If they change their diet, it affects their blood levels. So if they change their diet, specifically sodium, if they change their sodium intake, it affects their blood levels. Some signs of lithium toxicity are going to be things such as vomiting, diarrhea, confusion, tremors. So, lithium, we use it as a mood stabilizer and an antipsychotic. Bad thing about it, it has a narrow therapeutic range, and patients can develop lithium toxicity. We have to monitor their blood levels. You want to teach them to maintain their sodium intake, stay hydrated, and do not suddenly reduce dietary salt. Their sodium affects their lithium levels. They could possibly develop lithium toxicity. Signs of that are vomiting, diarrhea, confusion. When would be a time that we would use antipsychotics? What are they used for?
Bipolar.
Yeah, they can be used for bipolar. They're also used for schizophrenia or psychosis.
Anxiety or depression.
It could definitely be used for that in severe cases. Some examples of some antipsychotics are going to be things that end in your INE. So clonopine, thorazine, those are both antipsychotics. Clonopine, thorazine are antipsychotics that are used for schizophrenia. They can, like you said, be used for bipolar or severe cases of depression, psychosis. What medication do we use for Alzheimer's?
Levodopa, carbidopa.
That one's for your Parkinson's. We use the donepezil for your Alzheimer's. So Alzheimer's is going to be your donepezil. The goal of that medication is to slow progression, not cure. So the goal for that medication is to slow progression, not cure. We said that that medication was donepezil. It's used for Alzheimer's, and the goal is to slow progression, not cure. Just a second here. Let me take a peek through this really quick here. What do our corticosteroids do?
Decreases inflammation.
Yeah, absolutely. So your corticosteroids, they reduce inflammation and they suppress the immune response. Corticosteroids, they reduce inflammation and suppress the immune response.
They're
What
used
is
for like asthma, right?
it can be. Yep, it's you can sometimes see that given in asthma or with an acute asthma exacerbation or with COPD. And one of the common ones we use in the hospital is solumedrol. That would be considered a corticosteroid. What is the medication warfarin?
A blood thinner.
It is a blood thinner. And what lab value correlates to warfarin?
Is it a PTINR?
Yes, so it's going to be the PT-INR. The main one that we're going to be concerned about is the INR, but they are usually coupled together in the same lab. What is the medication furosemide?
Is that a diuretic? It's a Lasix.
The other name is Lasix, yes, and it is a diuretic. You're both correct. And what is the priority assessment with furosemide? If it's an antidiuretic, what does it do?
It lowers the sodium level.
It doesn't lower. It could lower your sodium level, but what does it do? It
eliminates fluid.
It gets
It-
rid of excess
yeah.
fluid. And whenever you're getting rid of excess fluid, what lab value does that affect?
Potassium.
Yes, it affects your potassium level. What is a normal potassium?
3.5 to 5.
Perfect. Give me an example of a proton pump inhibitor.
Pantoprazole.
That's a great one. Pantoprazole is a good one. Another one is going to be your omeprazole. So omeprazole is another one of the proton pump inhibitors, and these suppress acid. So your proton pump inhibitors suppress acid. An example is omeprazole. What is a common side effect of lisinopril? What is a It is a cough, so a dry cough. It's considered to be an adverse effect. So lisinopril, an adverse effect is a dry cough. Does anybody remember what it's caused by? So it's caused by an accumulation of bradykinin. So a dry cough, it's caused by an accumulation of bradykinin. What are some signs and symptoms of hypokalemia, low potassium? What are some signs and symptoms with low potassium?
Muscle aches.
Yep. What's the big one? The one that's the most concerning.
Uh,
Output.
broken bones.
U waves. So it's going to be related to the cardiac dysrhythmias. Yes. So what was it?
Heart palpitations.
They could have heart palpitations. Absolutely.
It's the
So
ST wave.
it is related to the ST wave and your cardiac dysrhythmias. So hypokalemia, some things you might see are going to be things such as muscle weakness, cardiac dysrhythmias, palpitations. Am I allowed to just hang IV potassium um without it being on a pump? Am I allowed to just let it run
No.
No,
by gravity? Why? Why does it need to be administered via a pump?
because it needs to go in slowly.
Okay. Is there anything else anybody wants to add on to that? She's right. She said it needs to go in slowly. Those
Well,
are
not just slowly, but over, like you can't essentially flood a person's body with a whole thing of
yeah, no, that's dangerous. That's dangerous. It's meant to be given with precise control. Um, we don't want it to be given in quickly. We want to be able to control that flow rate. Your IV potassium, if it's given rapidly, it can cause fatal dysrhythmias. So IV potassium always needs to be given with a pump. What's the antidote for acetaminophen? Antidote for acetaminophen.
is it charcoal?
It's not. The antidote for acetaminophen is going to be acetylcysteine. 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 What's a common side effect of statins? Common side effect of statins.
Muscle cramps.
Absolutely, muscle pain. What do we use to treat bacterial infections? This one's easy. Don't think too far into it.
Antibiotics.
Yes, antibiotics. We talked about bronchodilators and that they're used to treat asthma. What are signs and symptoms of hypoglycemia?
Diaphoretic and confusion.
Absolutely, perfect. So I was always taught that hypoglycemia, um, cold and clammy, need some candy. So things such as diaphoresis, confusion, those are all signs of hypoglycemia. The medication amlodipine, what classification is that?
Is it the antipsychotics?
So amlodipine is going to be your calcium channel blockers. Amlodipine is a calcium channel blocker. And those are used to lower blood pressure and heart rate. So amlodipine is a calcium channel blocker that's used to lower blood pressure and heart rate. Tell me a sign or a symptom of DIG toxicity.
Of what?
Dig toxicity, DIG, digoxin toxicity.
Dysrhythmias?
That is one. Yep, dysrhythmias could be one. Another one are going to be nausea, bradycardia. The hallmark sign are going to be your visual changes, though. A lot of people report seeing yellow green halos or blurred vision. So, your hallmark sign of dig toxicity is going to be visual disturbances. What medication do we use? Sorry, let me rewind here. What IV fluid do we use for dehydration?
Normal saline or lactated ringers?
And what kind of fluids are those? Isotonic, yes. So for dehydration, isotonic, and that would be your normal saline, which is 0.9% NaCl, or your lactated ringers. Both of those are correct. When we talked earlier about the furosemide or the Lasix, you told me that it was a diuretic. Tell me how a diuretic affects your blood pressure.
It decreases your blood pressure?
It does decrease it. How does it decrease it? What's it doing? How does it decrease your blood pressure?
Your heart isn't having to work as hard.
Yep, exactly. So it's getting rid of that fluid. They're usually peeing out the fluid, and it's removing the excess fluid, which treats the hypertension. It makes the blood pressure go down, um, and gives the heart a chance to not work as hard. Great. With heparin, what lab value do we monitor for heparin?
PT-INR?
So that was warfarin. Warfarin is specific to your PT-INR, but heparin, we monitor the APTT. And if you write those T's with little t's, you can remember that it's an H. That's how I always remember that. So we monitor the heparin with an APTT. We talked about the signs and symptoms of hypoglycemia. What is it called if a patient has hyperglycemia? What condition or disease is that called?
Is it
Diabetes.
Yep, it's called diabetes,
yes?
specifically diabetes mellitus. What assessment findings will you find with a patient that has fluid overload?
Hitting
Crackles, edema.
Pitting edema, crackles, all of those are true. Could also be increased weight. All of those would be indicative of fluid overload. What drug classification is used to reduce blood clots?
Anticoagulants.
Yes. We were talking earlier about patients with um, fluid overload. What if you have a patient that has shortness of breath, crackles, increased blood pressure? What if they're getting IV fluids? What do you do?
Stop the fluids.
Yes, for sure. Which IV solution increases intravascular volume? Which IV solution increases intravascular volume?
Hypotonic.
Hypotonic. I'm looking for colloid, your colloid solutions. They are going to increase your intravascular volume. What's the difference between phlebitis and infiltration? What does phlebitis look like?
It's more of like a streak, and it's the vein that's swelling.
Yeah, it's going to be red. It's going to be warm. It's going to have pain. Um, it's going to have that cord-like vein texture. That's your phlebitis. And your infiltration is going to be more what?
Cool.
Yes, it's going to be more cool. It's going to be more localized. What do you do if your patient gets an infiltration?
Stop the fluid if there's any running, and take out the IV.
Yep. So you want to stop the fluid, you want to take out the IV, and you want to elevate that extremity. What is sepsis?
It's an infection.
It's a very bad infection. It's life threatening. So sepsis is life threatening. It's when an infection enters the bloodstream. What is replacement therapy?
Replacing what needs to be replaced. So, like if they needed potassium, you put potassium, or if like electrolytes.
Perfect. So replacement therapy is used to replace fluids or electrolytes, commonly from what?
Dehydration.
Yep, related to vomiting or diarrhea. Exactly. Why does IV work the fastest?
Because so it doesn't have to go through the GI tract.
Okay, that's one reason. It doesn't have to go into the GI tract. It goes directly into the bloodstream. So that makes it work the fastest. Tell me something that an LPN cannot do as far as scope.
Administer blood products.
Okay, administer blood products is one.
IV narcotics or any push medication.
Yes, that's correct. What else?
Provide like first teaching on something. It has to be like the
Yeah.
RN or somebody has to have provided initial teaching first.
Yes, and you're kind of just reinforcing. So, are they allowed to give antibiotics?
Yes.
Are they allowed to administer TPN?
No.
No.
Perfect. There are going to be several what's called next gen case studies on this midterm. And if you haven't seen that yet, it's going to be very similar to what I have done with you during reviews. So you're going to kind of get a scenario. And then it's going to ask you a question. I'm going to go over an example of one with you so you know what I'm talking about. But there are several of those that are on your midterm, and it just gives you kind of like an assessment. It gives you a little scenario here. So an example of one here is going to be, you have a patient, they're 68 years old, they have a history of CHF and dehydration, you have IV fluids running, normal saline at 125. So that's a little bit of history on it. Your assessment, their blood pressure is 168/92. Their heart rate is 112. Their oxygen is 90. Whenever you're listening, their lung sounds, you hear crackles bilaterally, and they have +2 edema to their lower extremities. Which condition is the patient most likely experiencing?
Fluid overload.
Fluid overload.
Exactly. So that's kind of a little bit of what you'll see as far as those go. There's still multiple choice, so it won't be too. It just gives you a scenario and some kind of like assessment things.
Okay, so it's not like one of those where you have to like highlight the.
No,
Okay.
no. It's kind of just like set up just like we do in reviews sometimes, where I tell you a patient, and then it just basically asks you a question at the end.
Okay.
So branching off of that case study that we just talked about, what medication would you anticipate administering?
An antidiuretic for sure.
Yeah, absolutely. What's your priority action? What do you think you need to do first?
Stop the fluids.
Great. Yep. You guys told me that they were fluid volume overload. What findings support that?
Crackles and edema.
Perfect. I think that's all I have. Do you guys have any questions for me? If you sent me an email, I have been gone and I didn't take my computer with me. So I left on Sunday. I came back today. So if you have sent me an email, I will get to it. I apologize. I was on vacation. I did a vacation without my computer. So I will respond back if you have emailed me.
Please tell us what that's like.
Well, you're gonna have that soon, I promise. The last time I